Hi, I'm Dr. Robert Kaufmann, and we're about to go beyond the terminus. Today, we're going to talk about the cavity test. Is it a useful part of your tool chest? We've all been there. An acutely symptomatic patient comes in with a complex restorative treatment that makes diagnosis difficult. Sometimes all the posterior teeth have crowns or an extensive fixed prosthetic. Radiographs may show an entire side of radio-opaque crowns that are not much help in diagnosis. The patient presents with an irreversible pulpitis and symptoms that have not yet progressed to the periapical area. Because of this, the tooth is not percussion sensitive, and although they're in a great deal of discomfort, it's difficult for them to isolate the tooth because of the nature of the pulpal symptoms. We go through our normal tests, such as hot, cold, percussion, palpation, chewing tests, and peri-examination. We examine the bite-wing radiograph as well as the periapical image. In certain cases, we'll take a CVCT image because the cortical plates in the mandible often make it difficult for us to discern radiolucent findings in conventional imaging. We've assimilated all this information, and we have a tentative diagnosis. Now you've reached the intervention phase. If you're totally confident in your diagnosis, administration of local anesthetic is indicated, and you perform whatever treatment is necessary to get the patient comfortable. But what do you do in a situation where the diagnosis is not so clear-cut? The problem with administering an anesthetic is that it eliminates the ability to perform the final gold standard vitality test, the cavity test. As my late endodontist friend Dr. Joseph Dovgan used to say, sometimes you got to poke a hole in it. Seems a bit drastic, no? Well, actually it isn't. When there's any doubt, a cavity test should be part of the final determination as to whether the coronal aspect of the pulp is become necrotic. Occasionally, patients are sent to us with radiolucent findings at the apex of unknown origin, overlying anatomical foramina, segmental dysplasia, true cysts, and yes, even carcinogenic radiolucencies are all possibilities. When the radiolucent finding is of non-endodontic origin, usually a thermal test provides a positive response from the pulp. That is our indication that performing endo treatment on this tooth will not solve the problem. At that point, further evaluation and referral is probably necessary. For example, in the case of a suspected perio problem, to determine whether the tooth is salvageable periodontally or whether it requires extraction or prosthetic replacement. But sometimes thermal tests are ambiguous because of the presence of crowns or canal calcification, especially in older patients, where there may be some doubt as to the condition of the pulp. This is the definitive test. Although it's not frequently used, clinicians should not hesitate to use it when there's ambiguity as to the pulpal status or when all other tests have been performed without a diagnosis. We must remember that once an anesthetic is administered, this prevents us from performing any further pulp tests, and we are essentially committing the patient to treatment of a tooth in the anesthetized area. That's why the cavity test should be part of the diagnostic toolset of anybody considering endodontic treatment. When performing this test, it's very important to educate the patient about pulpal pathology and why the test is being performed. Obviously, patients will have a lot of trepidation about having a dentist drill into their tooth with no anesthetic. However, if you explain to them that the definitive diagnosis is based upon the results of this test, it helps to relieve their anxiety. A rubber dam is placed on the tooth. It's important the assistant placing the rubber dam explain because no anesthetic is being used. The rubber dam clamp may pinch on the gingiva a bit, or that this may feel a bit tight around the tooth. This is normal. Be gentle with the clamp. We must make sure that these sensations are not confused with a positive cavity test response. The clinician explains to the patient that if they have any sharp sensation at all, this test will stop immediately. The patient is in control. In the case of crowns, penetration into the metal of the crown occasionally causes the burr to chatter a bit, and the patient should be forewarned that this is normal. What we're looking for is a sharp response when we penetrate through the existing respiration or underlying core material. Once the dentin is encountered, if the tooth is vital, there should be a fairly sharp response. At that point, stop. Reevaluate your diagnosis and determine whether another course of action is indicated. If no sensation is encountered, enter the chamber. At that point, the diagnosis becomes apparent, and endodontic treatment is clearly indicated if there's no vital tissue in the chamber. In anterior teeth with radiolucent periapical findings, it's possible to do the entire treatment without a local anesthetic. And I do this very frequently. Patients are amazed. I do a lot of these cases in this manner, and patients are astonished that they can be treated without a local anesthetic. In multi-rooted cases, the situation can be more complicated. We know that endodontic disease generally proceeds coronally apically, and a radiolucent periapical finding may be present at the apex of one root and not at the others. This can indicate pulp vitality remaining in the other root with no finding. In those cases, we must administer an anesthetic to make sure the patient is comfortable. In all cases, should the patient have any sensation at all, we have to stop, remove the rubber dam, and administer the necessary anesthetic to make the patient comfortable. By using a cavity test, we ensure that teeth with periodontal problems are diagnosed properly and not incorrectly diagnosed and endodontically treated for a condition which is unrelated to any endodontic pathology. In acute cases, when we are asked to do something to help the acutely involved patient, this can mean the difference between correctly treating the symptomatic tooth or having to explain why one tooth was initially accessed in error and now two teeth, one of them adjacent to the previously treated tooth, now requires treatment. Remember, when we do the right thing, both of us get better, the patient and the clinician. Thanks for listening, and join me again when we take another trip beyond the terminus.